Welcome, Zooassembliers! My name is Zouk Azalishvili and I'm the founder of Zooassembly. Zooassembly is an online podcast for the highest yield basic science and clinical knowledge tested on UAssembly Step 1 and UAssembly Step 2 CK. The information discussed in this podcast is intended only for educational purposes. It's not intended to prevent, diagnose, or to treat the medical conditions in real clinical practice, nor is it intended to reflect the policy and the guidelines of various health institutions. Simply put, we serve you to butcher your step exams. Please subscribe to our podcast, Facebook, Instagram pages, and the YouTube channels down below in the description of this episode so that we keep you tuned for the news at Zooassembly. Now, let's start rolling. Today we are continuing our psychiatry series, and in this episode we'll start discussing the childhood psychiatry disorders. The first psychiatric diagnosis, which is almost always diagnosed in childhood, is the ADHD that I want to talk to you about. ADHD stands for Attention Deficit Hyperactivity Disorder, and the name gives us the symptoms and signs of ADHD. Let's break down the name. Attention Deficit Hyperactivity Disorder. This means that the children with ADHD have hard time focusing their attention on one particular thing at once, and at the same time they are hyperactive. They are hyperactive and also they are impulsive. Let's talk about these two sets of symptoms separately. Again, we have inattentive symptoms and then we have hyperactive and impulsive symptoms. Inattentive symptoms, include difficulty focusing on one subject at a time. Patients with ADHD are very distractible and they may not listen or follow somebody else's instructions. Inattentive symptoms also include forgetting to do the homework, for example. Sometimes children lose their objects and they may misplace the objects as well. Let's move on to the hyperactive and impulsive symptoms. So again, as the name implies, these children are hyperactive. So they are fidgety and they cannot sit still. They may be very talkative and they may interrupt the class and interrupt the classmates, for example, by blurting out the answers. You can imagine that patients with ADHD may have severe problems at school due to their fidgety and interruptive behavior. But importantly, children with ADHD usually have normal intelligence. It's very important in psychiatry to know the time ranges of the different diseases. In time ranges, I mean that different diseases need to last for a particular amount of time in order to diagnose the patient with that particular condition. For example, symptoms of ADHD should last for at least 6 months in order to diagnose the child with ADHD. At the same time, when we talk about the childhood psychiatry disorders, it's extremely important to know the age cutoffs. In case of ADHD, the symptoms should start before the age of 12. In other words, if the person exhibits inattentive symptoms in adolescence or young adulthood, but he or she has not had similar symptoms before the age of 12, this person cannot be considered to have ADHD, because ADHD should start before the age of 12. Another important criterion for ADHD is that symptoms should appear in at least two settings. And the most common settings where ADHD is exhibited by children is the home and school. And sometimes you will read in the cases that teachers call to the parents and they give the negative feedback about their child's behavior, and at the same time the parents cannot parents basically notice that the child is hyperactive at home as well. But very importantly, ADHD should cause functional impairment in order for it to be ADHD. Let me take a step back and explain a very important general theme in psychiatry. In order for something to be diagnosed as a disorder, it should cause functional impairment. And this is a very high yield idea. Every single disease in psychiatry, almost every disease, has a spectrum. It means that people may have the traits characteristic of that specific condition, but they may not be suffering from that condition because they still have control of their behavior. And their traits of a specific psychiatric condition does not interrupt with their daily functioning. For example, let me tell you my personal example. I feel like I have the traits of the obsessive compulsive disorder, and I also feel that I have traits of the obsessive compulsive personality disorder. However, these traits do not interfere with my day-to-day life, and it does not interfere with my relationships, either with the family or with friends or colleagues. That's why, again, in psychiatry, everything is a spectrum. Okay? Right. Let's get back to the ADHD. There are several subtypes of ADHD, and the subtypes are determined predominantly based on predominantly which symptoms are exhibited by the patient. Therefore, we can have predominantly inattentive ADHD. We can also have predominantly hyperactive and impulsive ADHD. And we can have the combined type ADHD. Importantly, when the child grows and this child has ADHD, the hyperactivity and impulsivity component usually subsides. And in adulthood, the attention deficit is what stays there, and therefore the child may be reclassified into ADD after she or he grows. ADD stands for Attention Deficit Disorder. Again, this is when the person exhibits the signs and symptoms of attention deficit, right? Forgetting things, misplacing the objects, difficulty focusing on one task at a time. However, they don't have the hyperactivity and impulsivity symptoms. Let's move on to the treatment of ADHD. Oh, but before then, I'm sorry, one very high yield thing that I'd like to tell you about ADHD is that attention deficit hyperactivity disorder commonly coexists with oppositional defiant disorder. We will discuss the ODD in a detail like after several minutes, okay? Now, the treatment of ADHD is different based off of the child's age. If the child is at the preschool age, then the first line intervention for ADHD is the parent-child therapy. This is the therapy for both parents and children, and this is when the parents learn how to set limits in a calm and non-punitive manner, and they start to realize how to interact with children with ADHD correctly. And only after parent-child therapy we prescribe stimulants to the preschool age children with ADHD. What I'm trying to say here is that, again, in preschool age children with ADHD, the first line therapy is parent-child behavioral therapy. And the second line therapy is the use of stimulants. Zeus Emilius, could you please give me the examples of the stimulant drugs? Absolutely. The stimulants include dextroamphetamine, methamphetamine, and methylphenidate, to name a few. And they can be used in the treatment of ADHD. Now, in contrast, when we have the school-aged kid with ADHD, the first line therapy is the stimulants, and the second line therapy is the parent-child therapy. Now, if stimulants do not help, like if one stimulant does not help the child, then we can switch to another stimulant. And if another stimulant doesn't help as well, then we can switch to the drug called atomoxetine. Atomoxetine is norepinephrine reuptake inhibitor. And the advantage of atomoxetine over the stimulants is that it has considerably low, almost absent risk of addiction. Now let me explain the idea behind this concept. We know that stimulants, methylphenidate, dextroamphetamine, and methamphetamine, work on both norepinephrine and dopamine. They inhibit the reuptake of both norepinephrine and dopamine, but they also release excessive norepinephrine and dopamine in the synaptic clefts. And we know that dopamine is responsible for the feeling of reward, and it's also involved in the pathophysiology of addiction. This is why the stimulants can be addictive. But atomoxetine, which works only on norepinephrine but not on dopamine, does not have that addictive potential. And then the second line medications for ADHD are alpha-2 agonists. Could you please remind me the examples of alpha-2 agonists? That's absolutely right. Here we are talking about the clonidine and guanfacine. We will talk about the side effects of the stimulants once we move on to the psychopharmacology, but let me give you a very quick side note here. Stimulants very commonly cause the weight loss and sleep disturbances, and they may even cause the exacerbation of the tics if the patient has pre-existing tics. But the weight loss and appetite suppression are most concerning symptoms, not symptoms, but adverse effects for the parents of the child. And very commonly, in order to avoid the appetite suppression, the stimulants are given after the meal. So after the child is fed, then we can give stimulants so that the child gets enough nutrition during the day. Okay, now that we've discussed the ADHD, let's move on to another disorder, and now we'll talk about the autism spectrum disorder. Autism spectrum disorder is usually diagnosed in an early childhood, particularly in the toddlerhood, around the age of 2, and sometimes it can be diagnosed before the age of 2. Patients with autism spectrum disorder typically have the deficits in the social communication and interaction with other people. They have trouble sharing their emotions and interests. If you see the patient with autism spectrum disorder, you may think that they are indifferent to other people's emotions and other people's interests. At the same time, they have impaired nonverbal communication. For example, they may have poor eye contact. And I have seen the patient exactly like this. This patient had very poor eye contact, and no matter how hard I tried to talk to him, he would not look me in the eyes. And as we already mentioned, patients with autism spectrum disorder have trouble developing the relationships with people and understanding the relationships with people. Additionally, a very important characteristic of autism spectrum disorder is the restricted and repetitive patterns of behavior. Let's take a step back and talk about what this means. First, patients with autism spectrum disorder typically exhibit the repetitive movements or repetitive speech. For example, they may spend the whole day arranging their toys in a specific order. I also know the patient who likes to shake the Coke bottle, and he can shake the Coke bottle with the Coke in it for the whole day if you don't interrupt him. Patients with autism spectrum disorder have very intense insistence on the sameness and on the routines, and they have fixated interests. If you imagine the child with normal development at the age of 2, then you probably think of the child who actively explores the world and wants to understand how everything works and takes interest in almost everything. But patients with autism spectrum disorder have fixated interests. For example, they may be very interested in their toys, but they won't go outside and play with other people, or they won't play with their siblings, so they won't communicate with their parents. They have fixated interests. And at the same time, they get very, very irritated to any sensory input, and especially if you try to interrupt their routine. So let's say that the patient with autism spectrum disorder loves to arrange his or her toys in a specific order. Now, if the parent or the guardian tries to interrupt his or her behavior, then the child may get very upset, may throw tantrums, and may become aggressive as well. Autism spectrum disorder is more common in males, and it is associated with increased size of the head and brain. Nobody really knows why the size of the head and brain increases, but the one hypothesis that I have heard is that it's as if the brain tries to compensate for those deficits that the patient has in several different domains. Additionally, autism spectrum disorder may or may not occur with the language and intellectual impairment. What I'm trying to say here is that not all patients with autism spectrum disorder have intellectual disability. And even more, some patients with autism spectrum disorder have something called savant syndrome, meaning they have unimaginable, outstanding ability in a specific field. For example, they may become outstanding physicists, or they may be outstanding musicians. That also happens in autism spectrum disorder. Now let's talk about the assessment and the management of patients with autism spectrum disorder. First, very importantly, the early diagnosis and intervention are crucial. The earlier we intervene in the development of the patient with autism spectrum disorder, the better the prognosis is in the future. And the treatment is the comprehensive, holistic approach. There is no one therapy or one medication that treats or cures the autism spectrum disorder. No, in contrast, the patients need the multimodal treatment. So speech therapists, behavioral therapists are involved in the management of these children, and they also need the special educational services. However, if the patient with the a patient with the autism spectrum disorder has the other psychiatric comorbidity, then this patient may need the adjunctive pharmacotherapy. But again, this pharmacotherapy is for the other comorbid psychiatric conditions, not for the autism spectrum disorder itself. Right, so we are now done with the autism spectrum disorder, and the next child psychiatric disorder that we are going to discuss is the conduct disorder. In a nutshell, the conduct disorder is the antisocial personality disorder before the age of 18. In other words, patients with conduct disorder are commonly reclassified as the antisocial personality disorder after the age of 18. And we'll talk more about the antisocial personality disorder when we discuss the personality disorders, but let's discuss the conduct disorder as well. They are very similar, if not identical, in terms of the presentation. Patients with conduct disorder commonly violate the societal norms, and they have no respect of the other people's basic rights. Children with conduct disorder may express the aggression towards other people. They may be involved in theft, in murder even. They may also be involved in torturing animals or destructing other people's property. And so again, a patient with conduct disorder has very common problems with the law because they perform the criminal acts. And the treatment for both conduct disorder and antisocial personality disorder is the cognitive behavioral therapy, shortly CBT. Now, conduct disorder is different from the oppositional defiant disorder, also known as ODD. As the name itself implies, patients with ODD are oppositional and they express the defiant behavior toward the authority figures. Now, authority figures may be parents or guardians. The authority figures may be the principal at school. So they have this constant protest against those authoritative figures, and they try to resist their requirements and their instructions anytime they can. But idea is that children with ODD do not usually have problems with law. They don't usually destroy the other people's property. They are not involved in criminal behavior or in severely aggressive behavior like harming the people or the animals. They are children who are simply angry and aggressive towards the authority figures. And another important distinction between the conduct disorder and the oppositional defiant disorder is that the patient with conduct disorder does not have the normal relationship with his or her peers. This is because the child with conduct disorder may harm the peers as well. They may beat up their peers, they may force someone into the sexual intercourse without their consent. And you can imagine that these children do not have healthy and satisfying relationships with their peers, not the friends. In contrast to the ODD, patients with oppositional defiant disorder usually get along really well with their peers. And the treatment for oppositional defiant disorder is again psychotherapy, specifically CBT, or cognitive behavioral therapy. And one more thing, the signs and symptoms of oppositional defiant disorder should last at least 6 months. Okay, now that we have discussed the conduct disorder and the oppositional defiant disorder, let's compare and contrast the disruptive mood dysregulation disorder, shortly DMDD, and intermittent explosive disorder. Let's start with DMDD. Disruptive mood dysregulation disorder should start before the age of 10. And as the name implies, the children with disruptive mood dysregulation disorder have difficulty regulating or controlling their disruptive mood. They have these recurrent outbursts, the temper outbursts or temper tantrums, out of proportion to the situation. Let's say that you touch the toy of the child with DMDD. The child may become so upset that they may express severe aggression towards you. They may try to beat you up and they may try to harm you. Very, very importantly, children with DMDD are constantly angry and they are constantly irritable even between the outbursts. So at the baseline, these are angry children. These are irritated children. And the way we treat the DMDD is by CBT, but at the same time, we can use the stimulants or antipsychotics as well. Now let's move on to the intermittent explosive disorder. Again, as the name implies, these children exhibit the intermittent explosion of their anger. And commonly, the intermittent explosive disorder persists into adulthood. It should start after the age of 6. Intermittent explosive disorder usually does not start before the age of 6. And again, patients with intermittent explosive disorder have these recurrent outbursts, either verbal or physical, which is out of proportion to the provocation. And the outburst here results from their inability to control their aggressive impulses. Let's take an example. Let's say that we have a patient who was diagnosed with intermittent explosive disorder in childhood, but now he is an adult. And let's say that you work with him in the company, and one day you occupied his parking spot. This person may get so upset and so aggressive that he or she may first damage your car and may actually try to harm you physically. And you can imagine that intermittent explosive disorder commonly leads to legal consequences and financial consequences as well. Needless to say that it has devastating social consequences because most people try to stay away from patients with intermittent explosive disorder because they become uncontrollable during their episodes. They become totally unpredictable and uncontrollable. Importantly, the episodes are not premeditated, which means that patients with intermittent explosive disorder don't plan out their episode of the outburst. It comes in a second, and it comes with a provocation. Usually, the episode of the intermittent explosive disorder lasts less than 30 minutes. And the most important distinguishing feature of DMDD and the intermittent explosive disorder is that patients with intermittent explosive disorder are in a normal mood at their baseline. So they are not angry and they're not irritable at baseline. They have the normal mood, they have normal affect, but if the provocative stimulus occurs, they may become unpredictable and uncontrollable. The way we manage the intermittent explosive disorder is again by psychotherapy, but here we use the SSRIs as well. Let's now discuss the intellectual disability versus specific learning disorder. And I'm trying to discuss the conditions, the childhood psychiatric conditions, which look like each other, and therefore they are commonly confused. We commonly confuse these conditions with each other. So let's start with intellectual disability. The word that I'd like you to remember for the intellectual disability is global dysfunction. These patients have global cognitive deficits, which means that they have dysfunction in every single cognitive domain, including the memory, reasoning, judgment, abstract thinking, learning, and language. So adaptive functioning is totally impaired, and you can imagine that this leads to difficulties with the education. These children cannot efficiently perceive the information and use that information. They commonly have problems with employment because it's very hard for them to find the appropriate job. And even more, sometimes it's very hard for people with intellectual disability to socialize and to communicate with other people. And depending on how impaired the patient's like how severe the intellectual disability is, the patient may have problems with independence. If the patient's IQ is very low, then these patients need constant supervision and someone should take care of them constantly. The way we treat the intellectual disability, not treat but manage, that's a more correct word, is that we do the psychotherapy to help them with their emotional struggles. We also advise the occupational therapy so that they learn they learn the tasks that they can perform and therefore they can work on their own. And they also need this special education. Now let's move on to the specific learning disorder. As the name implies, the patients with specific learning disorder have difficulty learning the one specific thing. We said that intellectual disability is a global dysfunction of all the cognitive domains, right? Whether it's judgment, whether it's reasoning, independence, and so on. But in case of specific learning disorder, the child has difficulty learning that specific subject. This might be math, it might be reading, writing, whatever. But here's the thing. The child should not be able to acquire or use the information from that particular subject near the age expected proficiency for at least 6 months despite the focused intervention. I know that this definition is a mouthful, but the reason I told you this is that I'd like to discuss it with you. I'd like to break down this definition with you. So, first, in order to diagnose the child with specific learning disorder, we should make sure that the child has difficulty acquiring the information near the age expected proficiency. Let me give you an example. If you give the equations and the formulas to the child, which are typically used by the masters and PhDs in mathematics and physics, well, there's no surprise that the child will not solve those equations and the formulas. But this does not mean that the child has a specific learning disorder. It simply means that these equations and formulas are too hard for the level of the child's education and child's development. At the same time, the inability to learn the specific subject should persist despite the focused intervention. The child may be lazy in that particular subject or may not like the subject, and this may be the reason for why child does not learn the subject. But then if we put an extra effort and if we, let's say, hire the individual tutors, but then child still cannot acquire enough information, then we can say that it's probably specific learning disorder. So again, we need to exclude the lack of interest and laziness before we say that the child has specific learning disorder. And finally, the signs of specific learning disorder should last at least 6 months. Again, the major distinction between intellectual disability and specific learning disorder is that in specific learning disorder, the general functioning and general intelligence are intact. And the way we manage the patients with specific learning disorder is by academic support. Again, they may need the extra classes or individual tutors in that particular subject. We also may need the psychosocial counseling. This is because children with specific learning disorder may have difficulties at school. They may be bullied or they may be laughed at by other people, by other classmates, and this is definitely very devastating for the child. So we need to perform the counseling as well. And then we need to arrange the extracurricular activities for the child with specific learning disorder. By extracurricular activities, we allow them to discover themselves in a particular field, and they can discover what they are brilliant at, right? So that they don't feel as the outliers, because they are not. So if you are not good at something, then you are definitely brilliant at the other thing. So you just need to find that right job or right thing for you. Okay. Now let's move on to the selective mutism. Selective mutism means that children are silent and quiet in selective environments. Selective mutism starts before the age of 5, and it's an anxiety disorder. So if the child gets into the environment where she or he feels anxious, they may not speak at all. And importantly, the speech and the language development is totally normal in selective mutism. The children with selective mutism can talk fluently in other more comfortable situations. So they just selectively, so there are certain situations or environments where they do not want to talk because of the anxiety. And you can imagine that this pattern of behavior strongly interferes with the social interactions with academic and occupational tasks. If school and if the environment full of classmates is anxiety provoking for the child with selective mutism, then this child won't speak at school. And if the child doesn't speak at school, first, she or he has trouble making friends with other people, and at the same time, the grades go down, so academic performance is poor. Very commonly, selective mutism coexists with social anxiety disorder or social phobia. We'll talk more about social anxiety disorder when we move on to the anxiety disorders. And finally, the treatment for selective mutism is primarily the psychotherapy. And psychotherapy, in this case, may involve several branches. So we can we can use the behavioral therapy, also family therapy, and the play therapy. Sometimes children with selective mutism also need DSSRIs. Now we'll discuss the separation anxiety disorder. As the name itself implies, the children with separation anxiety disorder have difficulty separating from their home or from the attachment figures like mother, father, or the guardian for a prolonged time. But before we talk about the separation anxiety disorder, let's remind ourselves when the separation anxiety normally starts. could you please remind me from our previous psychiatry episode when the separation anxiety appears in the child? I can hear you. Absolutely. It's around 9 months. And separation anxiety may be normal up until the age of 3 or 4. But if separation anxiety lasts beyond the age of 3 or 4 years, and if it lasts for at least 4 weeks with significant functional impairment, this is when we say that the child has separation anxiety disorder. And patients with separation anxiety disorder may have secondary psychiatric conditions like factitious disorder imposed on self or Munchausen syndrome, or they may even express the malingering. We'll talk about factitious disorder and malingering in detail in the following episodes of psychiatry, but for this moment, let me tell you that what this means is that the children come up with the different excuses or the symptoms for why they don't want to go to school. And in case of malingering, they may even falsify their symptoms. So this is separation anxiety disorder, and the last disorder from the childhood psychiatry that we need to discuss is the Tourette syndrome. Tourette syndrome should start before the age of 18, and the signs and symptoms of Tourette syndrome should persist for more than 1 year in order to diagnose the patient with Tourette syndrome. Now let's talk about the signs and symptoms of Tourette syndrome. Patients with Tourette syndrome have sudden, unexpected tics. And it's very high yield to remember that in order to diagnose the child with Tourette syndrome, she or he should have multiple motor tics and at least one vocal tic. And let me tell you the reason for why we put such a big emphasis on the diagnostic criteria here. We also have a disorder which is called the chronic tic disorder. In chronic tic disorder, the patient may have either vocal tics or motor tics, but not both of them together. And these tics also should last more than 1 year in order to diagnose the patient with chronic tic disorder. So we need to distinguish Tourette syndrome from chronic tic disorder. Again, in Tourette syndrome, the patient should exhibit multiple motor tics and at least one vocal tic. So it's AND. But in case of chronic tic disorder, the child either has the motor tic or tics or the vocal tic or vocal tics, but they're not present together. All right, let's move on to the, not move on, but let's get back to the Tourette syndrome. Some patients also exhibit the coprolalia. Coprolalia literally means involuntary obscene speech. And you can imagine how distressing this can be for the patients and for the people around the patient with Tourette syndrome. And this is why social education about Tourette syndrome is very important. Some people may think that the people with Tourette syndrome intentionally try to insult them, but it's not an intentional attempt to insult the other people. So they cannot hold these ideas within themselves, and they feel the urge to say everything that they feel and everything that they think, even if it's insulting to other people. Because if they don't say what they feel or think, they will feel a very big surge of anxiety. And this is why some patients with Tourette syndrome may have coprolalia. It's very high yield to know that Tourette syndrome is associated with obsessive compulsive disorder and the ADHD. I've literally seen the questions which test this association. So they may describe the classic patient with Tourette syndrome, and then they may ask, which of the following comorbid psychiatric condition may be present in this patient? And the answer in this question will either be OCD or ADHD. The way we manage Tourette syndrome is first by psychoeducation of the patient and the family. So we need to make the patient realize that it's not, how to say, they should not be ashamed of having Tourette syndrome. And we should also educate the family to be more accepting of the patient's signs and symptoms. The patient may also benefit from the behavioral therapy, but if tics are intractable and resistant to behavioral intervention, then we can start the pharmacotherapy. From the medications, we can use the tetrabenazine. Tetrabenazine is the dopamine depleter. It blocks the VMAT, vesicular monoamine transporter, in the noradrenergic synaptic clefts, and therefore, sorry, not synaptic clefts, but presynaptic terminals, and therefore it blocks the release of dopamine. We can also use antipsychotics and finally alpha-2 agonists like clonidine and guanfacine in the treatment of Tourette syndrome. Okay, so now we're done with the childhood psychiatric disorders, and let's discuss what the orientation means. The orientation is the person's ability to know what time it is, the place they are in, and who they are. So it's the correct perception of the time, place, and person. The reason we talk about orientation in psychiatry is that many conditions, either psychiatric or non-psychiatric conditions, can present with loss of orientation, also known as disorientation. The order of loss in disorientation is time, place, and person. In other words, the person first loses the sense of time. So they don't know what time it is, what year it is, which day of the week it is. And if you think about it a little bit deeply, you can realize that loss of time perception is really easy compared to loss of perception of the place and of the person's identity. For example, I can tell you my personal experience with this. Well, when I was the high school student, I absolutely had loss of time perception in summer. So I was not checking the calendar and I was not checking the time. So I usually did not know which day it was. And yeah, so I was a little disoriented in time. But after the disorientation in time, the person then loses the orientation of the place. So they don't realize where they are. And finally, they lose the perception of their own identity. And it makes sense that the loss of perception of the identity comes last, because identity is the core of personality of all of us, right? Like of the different people. So it's the core information. It's very personal, and it's there, and therefore it's very hard to lose the perception of your own identity. The differential diagnosis of disorientation is unimaginably vast. As we already mentioned, disorientation can happen either due to psychiatric conditions or non-psychiatric conditions, and most commonly it's due to non-psychiatric conditions like alcohol intoxication. It might be drug intoxication or withdrawal. The patient may experience the head trauma followed by the disorientation. The reason for disorientation may also be the food imbalance, let's say dehydration or electrolyte imbalances, hypoglycemia, hypoxia, nutritional deficiencies like thiamine deficiency causing Wernicke-Korsakov syndrome. So again, there are many different causes of disorientation, And the main thing that we need to know about disorientation is the order of loss. So again, just to remind ourselves, at first, the person loses the perception of the time. Secondly, the person loses perception of the place. And the last thing, the perception of which is lost, is personality, or the person's identity. Let me tell you about Match a Resident. Match a Resident is an organization that helps residency applicants find the perfect residency programs for them. Although it's particularly helpful for international medical graduates, anyone is welcome to Match a Resident. It is trusted by over 150,000 international medical graduates for over 17 years. Match a Resident gives you detailed information about each program's requirements, such as visa status, USMLE scores, and more. Match a Resident annually updates these requirements through in-person conversation with program coordinators every year to give you the newest information possible. This way, you invest your time and money in the residency programs where you have high chances of matching. To find out more about this amazing organization, check out the website www.matcharesident.com. Match a Resident is the path to your success. Now let's move on to the different types of amnesia. Amnesia is the inability to recall the past memories or acquire the new memories. As you can already imagine, we have two major types of amnesia, the retrograde and anterograde amnesia. The retrograde amnesia means that the person cannot remember things that occurred before a CNS insult. Let's say that the patient got into a major motor vehicle accident, and let's say that he or she had the diffuse brain injury. After this, if the patient cannot remember his or her past or specific time periods from his past life, then we can say that the patient suffers from retrograde amnesia. In contrast, the anterograde amnesia means that the person cannot remember the things that occur after the CNS insult. So they have decreased acquisition of the new memories. They cannot remember the new people that they meet after the CNS insult, and they cannot remember the new events and new moments after the CNS insult. And then there is the specific type of amnesia, which actually includes both anterograde and retrograde, and it's called Korsakov Syndrome. We'll talk more about Korsakov Syndrome when we discuss the alcohol use disorder later in the Psychiatry series, but let me tell you high-yield things about Korsakov Syndrome here. The reason we are discussing Korsakov Syndrome along with the other types of amnesia is that Korsakov Syndrome is characterized by both anterograde and retrograde amnesia. However, could you please tell me which type of amnesia is prominent in Korsakov Syndrome? Is it retrograde or anterograde? I really hope that all of you are saying anterograde amnesia. So anterograde amnesia is more prominent in Korsakov Syndrome than retrograde amnesia. Korsakov Syndrome is also characterized by personality changes and confabulations. Confabulation is when the patient makes up the stories about the past events of her or his life. But the thing is that confabulation is not a lie. The person is not lying when she or he is exhibiting confabulation. So if I remember some kind of past event in a great detail and I'm telling you the different version of that event, that's a lie. But they don't remember what was present in that particular moment in the past, but then they make up the story. and they believe that that was what happened. So again, confabulation is not the same thing as lie, and it's characteristic for Korsakov syndrome. Korsakov syndrome, as well as the Wernicke's encephalopathy, are caused by chronic alcohol use over the course of years. And it's very high yield to know that the symptoms of both Wernicke's encephalopathy and Korsakov syndrome result from thiamine or B1 deficiency. It's the vitamin B1, and we know that thiamine is essential for ATP production because it's the cofactor for several different enzymes in the basically, for example, pyruvate dehydrogenase complex, and also B1 is the cofactor for several enzymes in the Krebs cycle. So you can imagine that if a patient with chronic alcohol use has thiamine deficiency, then there is insufficient ATP production in their brains. And there are specific brain areas which are damaged in Wernicke-Korsakov syndrome. These are the mammillary bodies, which are the part of the limbic system, and the anterior part of the thalamus, and also dorsomedial nuclei of the thalamus. Wernicke's encephalopathy is reversible, while Korsakov's psychosis or Korsakov syndrome is irreversible. To put it another way, Korsakov syndrome follows Wernicke's encephalopathy. Okay, so more on this later in the psych series when we talk about the chronic alcohol use disorder. Now we'll talk about the dissociative disorders. Dissociative disorders are called so because in these disorders, the patients dissociate from themselves. Let me explain a little better. All three types of dissociative disorders are usually preceded by a very severe trauma, especially in childhood. And this trauma is most commonly the physical abuse or either sexual abuse. Dissociative disorders, statistically speaking, is more common in females. And in the order of growing severity, we have Depersonalization Derealization Disorder, shortly called DDD. We also have dissociative amnesia with or without dissociative fugue. And finally, the most severe subtype of dissociative disorder is dissociative identity disorder, formerly known as multiple personality disorder. Let's start with depersonalization derealization disorder. Again, just like any other dissociative disorder, depersonalization derealization disorder is also preceded by a very severe trauma, especially in childhood. And this trauma is usually abuse, and most likely it's the sexual abuse. In that case, the person's consciousness tries to detach from the person's body and estrange from the person's body in order not to recall that painful memory. And the person experiences depersonalization and derealization. Could you please tell me what depersonalization means? That's abso-freaking-lutely right. Depersonalization means that you dissociate from your own consciousness and identity and your person. So you dissociate from your own body and thoughts and your perceptions, and people commonly describe depersonalization as if they come out of their own body and they look at themselves from the outside, or they describe it as if they are floating all over themselves from the outside. Derealization is different. Derealization means that the person feels that the environment around herself or himself is not real. So the environment that they know, for example, their house, their bedroom, it feels unreal and it feels strange. Very importantly, the patients with depersonalization derealization disorder have an intact perception of reality and intact reality testing. In other words, although they experience depersonalization and derealization, they know who they are and they know that the environment that they are in is real. They simply feel that it's unreal. And this is in contrast to psychosis. Patients who experience a psychotic episode cannot differentiate the real from unreal. So for them, the, let's say, visual or auditory hallucinations are just as real as the environment that they are in. And we'll talk more about psychosis a little later, so let's get back to the dissociative disorders. Again, so now we have discussed the depersonalization and derealization disorder, and let's move to dissociative amnesia. Dissociative amnesia means that the person cannot recall important autobiographical or personal information. So they may forget who they are. They may forget their first name, last name, their family. They may forget where they live. And all of this occurs after that severe trauma, especially the different types of abuse. The dissociative amnesia can be followed or can be accompanied by dissociative fugue. Dissociative fugue is when the patient goes and travels away from home in the state of amnesia. So they don't remember who they are, they don't remember where they live, who their family is, and then they travel. And they may travel from one city to another city. They may travel even from one country to another country. And if they ever recall that important personal information, then they have no idea how they ended up in another country because they performed this dissociative fugue in the state of dissociative amnesia. Right, and then the last type of dissociative disorder is dissociative identity disorder. As we already mentioned, it was formerly called the multiple personality disorder. This is when the person's identity is broken down into several different identities. So a person has at least two distinct personality states or identities, and each personality state has its own memory, its own background, the history. And the idea here is that the consciousness tries to protect the person from that painful past memory by creating several different personalities who can deal with that memory or who have no recollection of that painful memory that happened in childhood. Again, just like any dissociative disorder, the dissociative identity disorder is also more common in females. And commonly, the patients with dissociative identity disorder have memory gaps. The memory gaps arise from the points in time when they transition from one personality state to another personality state. And sometimes the personality states may be aware of each other. So the person may know that he or she has multiple different personalities. And mostly that's due to the people around these patients, especially family members. You can imagine that for family members, the dissociative identity disorder is very frightening and very devastating, and they may try to talk to the patient that they change their behavior and they change their personality multiple times a day. So this is how the person with dissociative identity disorder may discover that she or he has multiple different personality states. And I am not sure if I remember it correctly, but I have watched an interview on Oprah. I think it's a very old interview from the Oprah show, and I think the video is there on YouTube, and I watched the video of the lady who had, as I remember, 93 or 96 different personalities. I'm not sure about the number, but I'm sure that the number was huge, and I don't know, I was in shock when I watched that video. And this lady talks about her traumatic past experiences. So again, like if you'd like to know more about patients with dissociative identity disorder, I would like to encourage you to look up the videos and to hear their stories and to try to understand how these people may feel and may perceive the world. Okay, now that we are done with the dissociative disorders, let's move on to the delirium. Delirium is the acute condition of waxing and waning level of consciousness. When the person develops delirium, they commonly have a severely decreased attention span, and they may also exhibit the decreased level of arousal. Delirium most commonly occurs in the elderly patients, and in addition to decreased attention span and decreased level of arousal, they may also have the other symptoms, mostly psychotic symptoms like disorganized thinking, and we'll talk about the types of disorganized thinking in a minute when we discuss the psychosis. They may also have the hallucinations, and the prominent type of hallucination in case of delirium is the visual one. They may also have disturbed sleep-wake cycle. What I mean here is that delirious patients may stay awake throughout the whole night, and they may be sleepy and they may fall asleep during the day. And they may also be very agitated. The state of delirium is almost always reversible. And let's take a step back and compare and contrast delirium versus dementia, because I realize that some of us confuse delirium and dementia, so I'd like to draw your attention to the distinction between these two conditions. Again, as we already said, delirium is a very acute condition. It can start in a day. In contrast, dementia is not an acute condition. It's most commonly the chronic condition that's protracted over the course of months and most commonly the years. At the same time, delirium is reversible. And we'll talk about the different causes of delirium that we can reverse. However, dementia is almost always irreversible. So again, the two major distinctions between delirium and dementia is the acuity versus chronicity and reversibility versus irreversibility. Additionally, delirium is the secondary manifestation of some other ongoing process in the body. So delirium is usually not the primary condition. It's secondary to some other condition, while dementia is the primary neurodegenerative condition. As we already mentioned, delirium is usually secondary to other identifiable illnesses, and these illnesses may include the central nervous system and also any other organ system. So again, delirium may happen in patients with CNS disease, for example, dementia. So what I'm saying here is that demented patients may acutely develop delirium, or delirium may be superimposed over dementia. Also, CNS infection or any other infection can cause delirium. Trauma can induce delirium. Substance use or substance withdrawal can be responsible for delirium as well. Additionally, things like electrolyte disturbances, metabolic disturbances, hypoglycemia, or infections like UTI, they can all induce delirium, especially in elderly people. Even the things as benign as fecal retention and urinary retention can basically produce the delirium. Sorry, not produce, but precipitate delirium, excuse me. And then there are certain medications which can either precipitate or exacerbate delirium. let me give you a general rule of thumb. Any medication that sedates the patient and decreases the higher cognitive functions can potentially induce or exacerbate delirium. These medications include anticholinergics, for example, also benzos and opioids. They can all induce or exacerbate delirium. This is why we avoid these medications as much as we can when the patient has delirium. Delirium is the most common cause of disorientation and the altered mental status in the inpatient setting, and especially in the ICU patients. A very important risk factor for delirium is the prolonged hospital stays, especially in demented elderly patients. When the patient has dementia, any type of dementia, it's always best to keep him or her in the environment that he or she is used to the most. Let's say, so it's best to keep them at their own homes because they know the environment best and they can orient themselves in this environment. But when they change the environment, let's say they get readmitted to the hospital for some other reason, let's say it's CHF exacerbation, and if they have prolonged hospital stay, that can precipitate delirium. If we perform the EEG or electroencephalography on the patient with delirium, we'll see that there is a diffuse slowing of the background rhythm. So in all leads, we'll see that the frequency of the discharges is decreased. We'll see the delta frequencies, we'll see mostly theta frequencies, but as we know, the conscious awake patient should normally have the beta frequencies, right, which are the frequencies more than 13 hertz. Okay, now then the question is, how do we treat the delirium? Well, as we already mentioned, delirium is usually secondary to something else, and therefore the main idea in treating delirium is to treat the underlying condition, whether it's electrolyte disturbances, hypoglycemia, infection, substance intoxication, or withdrawal. Like, we need to treat the underlying condition, and delirium will gradually subside after treating that underlying condition. However, there are certain measures that we can use to alleviate the symptoms of delirium, or at least to shorten the duration of delirium. So first, we need to reorient the patient by keeping the clock and the calendar in the patient's room. Again, let's remember that delirious patients are disoriented. They may not know what time it is, what year it is. They may not know where they are, and in severe cases, they may not know who they are. So we need to keep the calendar and the clock in their room so that they can reorient themselves. At the same time, it's usually beneficial to basically keep the pictures of the family members in the patient's room so that they can recall their family. This will help them in reorientation. Additionally, we need to place delirious patients in the quiet and calm rooms because extra noise and excessive agitation and tension in the different words may exacerbate delirium in the patient. Finally, it's very beneficial to have the windows in the room of the delirious patient. The reason why windows are important is that through the windows, the delirious patient can see when it's the day and when it's night. We already mentioned that their sleep-wake cycle is disturbed, and they may sleep during day and they may be agitated and awake at night. But if they can see the day and night through the windows, that can help them to reorient to the normal sleep-wake schedule. Okay, now we can potentially use the antipsychotics if those behavioral modifications don't help, and haloperidol is commonly used for this purpose. That's why it's called vitamin H sometimes. the important thing to remember in the management of delirium is that we need to avoid unnecessary physical restraints because that can further agitate the patient. And again, as we already mentioned, we need to avoid the drugs which can exacerbate delirium. And these drugs include every drug that can sedate the patient and decline the higher cognitive functions, like benzodiazepines and opioids or anticholinergic agents. Okay, now we are done with the delirium, and the next topic that we're going to discuss is psychosis. The psychosis, the official definition of psychosis is distorted perception of reality. Let's talk about what this means. Distorted perception of reality means that you lose control of sensing what's real and what's not real. And you may feel the things that are not real, but you still think that they are real. The three main manifestations of psychosis are delusions, hallucinations, and disorganized thought and speech. You don't necessarily have to have all three of them at the same time in order for the patient to be considered psychotic. The patient may have only delusions, only hallucinations, or only disorganized speech, which is actually rare, and she or he can still be considered to be psychotic. Another important thing about psychosis is that psychosis is not a separate diagnostic entity, or it's not a separate disease entity. Instead, psychosis is the manifestation of some other underlying condition, whether it's medical or psychiatric condition. Okay, so again, psychosis can accompany both medical illnesses, psychiatric illnesses, or both. For example, psychotic disorders are called psychotic disorders because they are accompanied by at least one of these manifestations of psychosis. But in addition to psychotic disorders, even mood disorders and sometimes the anxiety disorders can present with some psychotic components. Okay, let's talk about these three manifestations one at a time. And the first one that we're going to talk about is delusion. In a nutshell, delusion is the fixed, false belief that almost nobody can talk the patient out of. So the patient believes something unreal and believes it so firmly that even if you present the counter arguments, they won't believe you. They will still stay on their opinion and they will still continue to believe what they believe in. Very importantly, in order for the thought to be considered as a delusion, it should not be typical for the patient's culture or the patient's religious beliefs. If the thought is congruent or correspondent to the patient's cultural beliefs or religious beliefs, that's not delusion. That's the part of the culture or part of a religion. But if it's something very strange and very weird, then we can consider it as a delusion. There are different types of delusions. We can have aerotomatic delusions. Aerotomatic delusion is when the person firmly believes that somebody else, especially the celebrities, are in love with them. We can also have the grandiose delusions. As the name implies, the patient with grandiose delusions think that they have control over everything, or they have superpowers, or they are the king of the world, or they're the god. So they have the grandiose, self-inflated perception of their own self. Delusion, so we can also have the jealous delusion. Jealous delusion is when the person thinks and firmly believes that his or her partner cheats on him or her. And I'd like to distinguish the jealous delusion from paranoid personality disorder here. We'll talk about paranoid personality disorder when we discuss the personality disorders, but paranoid personality disorder is pervasive. It's about all people, it's about all situations, not only the partner. And it doesn't necessarily, the paranoid personality disorder does not necessarily have to do something with the jealousy. So it's the feeling that all the people and the whole world is conspiring behind you to harm you. But when we talk about jealous delusion, this is when you specifically believe that your partner cheats on you. Okay? Right. Also, we can have the persecutory delusion. This is when the person firmly believes that other people are out to get them or catch them. We can also have somatic delusions. This is when the patient thinks that there's something wrong with their body. They may think that there is some mark or some defect on their skin, and they may even think that part of their body is dead. There is this very interesting delusional disorder. We'll talk about delusional disorders in a second, but I am mentioning this along with the somatic delusions because this is where somatic delusions are the weirdest and the strangest. So this syndrome is called Cotard Syndrome. Cotard, Cotard Syndrome. Patients with Cotard Syndrome firmly believe that either parts of their body are dead or they believe that they are dead. So they have these somatic and nihilistic delusions. There's another delusional disorder which has a very specific type of delusion. It's called Capgras syndrome. I don't know if I pronounce it correctly. I have always pronounced it as Capgras syndrome. It spells like Capgras, Capgras syndrome. It's also known as the imposter syndrome because patients with Capgras syndrome have delusions according to which their loved ones, their significant ones, are replaced by other creatures and beings like the aliens. So if their family member, the partner, or simply their acquaintance visits the patient with Capgras syndrome, the patient may think that this person standing in front of them is an imposter. It's actually another being or the creature who has replaced their loved one or significant other. Okay, the persons may also have the mixed delusions, and sometimes delusion can be unspecified. Okay, this was delusion. Now let's move on to the disorganized thought. As the name implies, the disorganized thought is disrupted thought process. It's very important to distinguish thought content and the thought process when we discuss the psychosis. Thought content is what you think. For example, delusion or hallucination is the thought content. Sorry, not hallucination. I mean, only delusion is the thought content. But thought process is the way you think. And disorganized thought is the disruption, is the thought process rather than the content. There are several different types of disorganized thought. For example, the patient may have incoherent speech, also known as the word salad. This is when the patient literally throws out the words in a random, unrelated order. For example, patient may say words like, I don't know, the book, the bed, pen, pillow. The words that don't make sense, they do not make up the sentence, so you cannot make the sense out of it. This is what's called word salad. The patient with psychosis may also have tangential speech. Tangential speech is when you tell the different stories or when you say the different sentences which are related to each other, but they do not respond to the question that was asked. Let's say I asked the patient, the year of their graduation from the high school, or I asked them to recall their, I don't know, recall one of their parties, they will start talking about some other memory or some other topic, and they will continue to talk about the other topics, but they will never answer my question. They will never describe their party, they will never tell me the year of their graduation. That's actually different from the derailment or loose associations. Similar to the tangential speech, derailment means that you don't answer the particular question, but derailment represents the loose associations between the stories. So I tell you several different stories, but they are totally unrelated to each other. So they have loose association with each other. So if you ask me the date of my graduation, then I may talk to you about my birthday party, and then I can rapidly jump off to speak about, I don't know, my flight to Turkey, let's say. So again, the stories don't have connections in derailment. Another type of disorganized thought is the circumferential speech. As the name implies, circumferential speech includes telling the different stories, but finally you get to answer the question that was asked. If you asked me the date of my graduation, first I can start talking about my childhood, my adolescence, and then I will finally go back and tell you the year of my graduation. So that would be considered as the circumferential speech. Another type of disorganized thought is the perseverance. It's very easy to understand perseverance. It's when you repeat one word nonstop. So you persevere on that one word. That's perseverance. Thought blocking is when your thoughts are blocked, or like you had a thought, but then the thought was interrupted and you cannot continue the Now I hope you understand what the thought block is. So you have a thought and you cannot continue the sentence because your thought process was blocked at some point. And thought blocking as the manifestation of disorganized thought is not the same thing as blocking, which is the defense mechanism. I know we have not discussed blocking in the defense mechanism episode, and this is because it's not typically listed in the defense mechanism tables. However, there is the defense mechanism called blocking. This is when you block the thoughts which are anxiety provoking or awkward for you. But this is not the same thing as the thought block in psychosis. In case of thought block, the content of your thought doesn't have to be anxiety provoking or awkward for you. The thought content can be anything. Simply your thought process is interrupted, and that's it. You cannot continue what you were talking about. Let me tell you about another type of disorganized thought. This is called clanging. Clanging is when you rhyme the words. So you pick up one word, let's say book, and then you say the words which rhyme with the word book. Let's say look or hook. I don't know, things like this. Okay, these were the types of disorganized thought. Again, we have incoherent speech, also known as the word salad, tangential speech, derailment, also known as loose association. We also have circumferential speech, perseverance, thought block, and clanging. And the final and the last manifestation of psychosis is the hallucinations. Hallucination is when you feel, when you see, or when you hear something that's not there. this is in contrast to illusion. Let's make a very distinct line of difference between hallucination and illusion. Illusion is misperception of the real external stimulus. For example, let's say it's night, and let's say that there are curtains and they make the shadow, and for a second you think that there's someone behind the shadow, or it's somebody else's shadow who is hiding behind the curtains. So in this case, there is the real external stimulus, which is the shadow, but you misinterpreted this stimulus, or you misperceived the stimulus. In case of hallucination, there is no stimulus. Let's say that it's a day, and then you see someone else behind the curtains. That would be hallucinations, because that there is no shadow, there's no external stimulus which may prompt you to think that there is someone behind the curtains, but you still see someone. That's hallucination. So hallucination is perception of the thing when there is no external stimulus. And there are different types of hallucination. For example, we have auditory hallucinations, when the patient hears the voices that nobody else can hear. And auditory hallucinations are more common with the psychiatric diagnosis, like schizophrenia, for example. We also have the visual hallucinations, and visual hallucinations is when you see the things or you see the people that nobody else can see. Visual hallucinations are more common with the medical illnesses. It can be drug intoxication, or it can be, in case of delirium, as we already mentioned. We also have the tactile stimulation. This is when you feel that something is crawling up on your skin. Usually the patients feel or see that the bugs are or beetles are crawling on their skin. And tactile hallucinations have very specific causes. They are most commonly seen in alcohol withdrawal, and they are also seen with stimulant intoxication. This is why tactile hallucinations are sometimes called the cocaine crawlies or delusional parasitosis. Then here we have probably the strangest types of hallucinations, which is olfactory and gustatory hallucinations. Olfactory hallucination is when you smell something that's not there. Most commonly, people feel the smell of the burning rubber, and that happens as an aura for the temporal lobe epilepsy. Again, temporal lobe epilepsy can be preceded by olfactory hallucination. This is because the piriform process, which is responsible for the smell, is located in the medial temporal lobe. Olfactory hallucinations are also common in case of brain tumors. Gustatory hallucination is probably the rarest type of hallucination, and it's when you taste something that's not there. So you feel the taste in your mouth of something that you have not tasted, and it's commonly seen in epilepsy. The last two types of hallucinations that we have to talk about are commonly seen in patients with narcolepsy. We'll discuss narcolepsy in detail in the further episodes of Psychiatry series, but here we'll talk about these two types of hallucinations. We have hypnagogic and hypnopompic hallucinations. Hypnagogic hallucination is any type of hallucination, whether it's auditory, visual, or tactile, happening when you go to bed. When you go to sleep, that's when you that's when you experience the hypnagogic hallucinations. In contrast, the hypnopompic hallucination is any type of hallucination, whether it's auditory or visual or tactile or olfactory, when you wake up from sleep. So it happens in the morning. Okay, so this was discussion of psychosis with its different manifestations, specifically delusion, disorganized thought, and hallucination. Now we'll talk about the schizophrenia spectrum disorders. Schizophrenia is the first disease that I'd like to discuss with you in the schizophrenia spectrum disorders. Schizophrenia is a chronic psychiatric condition, and it causes very severe, very profound functional impairment. And this is very high yield. In order to diagnose schizophrenia, the patient should have decreased functioning. That's one of the criteria for schizophrenia. This is in contrast to schizophreniform disorder that we'll talk about in a bit, which does not have to be accompanied uh, with decreased functioning. But schizophrenia has to be accompanied with decreased functioning in order to diagnose the patient with actual schizophrenia. There are three main categories or the sets of symptoms. Patients with schizophrenia may experience the positive symptoms, the negative symptoms, and the cognitive symptoms. Now let's define the terms positive and negative in the field of psychiatry. When we say positive symptoms, we mean the symptoms which are usually absent in a healthy individual. So they are the additive symptoms. But when we say that the patient experiences the negative symptoms, we mean that these are the symptoms or deficiency of the traits which are normally present in a healthy individual. But the patients with psychiatric conditions lack those traits and they have these negative symptoms. Let me give you examples and you will understand what I'm talking about. Positive symptoms are the symptoms of psychosis. In other words, positive symptoms include hallucinations, delusions, and disorganized thought and speech, and an overall bizarre behavior. So positive thoughts and psychosis are the same things. The negative symptoms are the symptoms resembling the depression. So what I'm not trying to say that schizophrenia is accompanied by depression. Please don't get me wrong. I'm trying to say that negative symptoms look like the symptoms of depression. So the patient may have the flat affect or blunted affect. Flat affect means that you do not react to any like positive or negative stimulus. Like if somebody tells you something happy, then you will maintain your facial expression without any change. If someone tells you something tragic, again, you will maintain your facial expression without any change. When we say the blunted affect, it means that you will still have some change of your facial expressions and the way you behave, but it won't be proportionate to the scale of what you're told. If somebody tells you something happy, then you may brighten up a bit, but it won't be proportionate to the thing that you've heard. The same thing is for the tragic or negative news. The patients with negative symptoms may also experience apathy and anhedonia. Anhedonia literally means the loss of experiencing pleasure. We commonly interpret the anhedonia as the loss of interest, but the more correct way of describing anhedonia is loss of experiencing pleasure from the activities that used to give you the pleasure in the past. The patients with schizophrenia and the negative symptoms may also have the alogia. So A is the negative prefix, which means no, and logos means word in Greek, right? So alogia means no word. So it's poverty of speech. And finally, negative symptoms also include the social withdrawal. It's very important to know that positive symptoms are caused by excessive dopamine concentration in the mesolimbic dopaminergic pathway. Could you please remind me where the mesolimbic dopaminergic pathway starts? Exactly, it starts in the midbrain, specifically from the area called VTA or ventral tegmental area. And since it's mesolimbic system, it means that it ends in the limbic system, specifically in the nucleus accumbens. And when dopamine levels are increased in this pathway, this is what causes the positive symptoms or psychotic symptoms. In contrast, the negative symptoms are caused by decreased dopamine concentration in the mesocortical pathway. Mesocortical pathway, as the name implies, starts from the midbrain. That's why the word mesocortical starts with the word meso. Meso means mesencephalon, or the midbrain. It starts from the midbrain and then it disseminates throughout the whole cortex. And the normal dopamine concentration in the mesocortical pathway is necessary for our normal and healthy relationships with the outside world and normal affect, the ability to experience pleasure. So if you have decreased dopamine levels in the mesocortical pathway, this is when you get the negative symptoms of schizophrenia. And the last subset of symptoms are the cognitive symptoms. Cognitive symptoms include the inability to understand the plans or to make the plans. Also, the patients with schizophrenia and cognitive symptoms may have diminished working memory and they may have decreased attention span. Okay, now that we've talked about the symptoms, let's talk about the diagnostic criteria for schizophrenia. In order to diagnose the schizophrenia, the patient should have at least 2 of the 5 symptoms that we are going to list now, and at least one of these 2 symptoms should be the positive symptom. So those 5 symptoms are hallucinations, often auditory, delusions, disorganized thought and speech, disorganized or catatonic behavior, and the negative symptoms. When the patient meets at least 2 out of these 5 symptoms, and at least one of that 2 symptoms is the positive symptom, we can say that the patient has schizophrenia. But before we do this, there's a time frame that's very important in schizophrenia spectrum disorders. In order to diagnose someone with schizophrenia, his or her symptoms should last at least 6 months before we make the diagnosis. The active disease should last at least 1 month out of these 6 months. I know that it sounds confusing, but let me explain. So when we say that patient's symptoms should last at least 6 months before we diagnose schizophrenia, we mean that both like prodromal symptoms, which are mostly negative symptoms, the active symptoms, and the residual symptoms should all last at least 6 months. But the active symptoms, which are mostly the positive symptoms, should last at least 1 month out of these 6 months. Okay, now let's talk about the other changes of the neurotransmitters and the other CNS changes in schizophrenia. We already talked about the different dopaminergic activities in the mesocortical and mesolimbic pathways, but schizophrenia is also associated with increased serotonergic activity. And the neurons in the brain of a schizophrenic patient has decreased dendritic branching. If we perform the imaging on patient with schizophrenia, we may see the ventriculomegaly. So this will be ex vacuo ventriculomegaly, right? It looks like the hydrocephalus, but it's not the hydrocephalus, right? This hydrocephalus mimics. The prevalence, lifetime prevalence for schizophrenia is approximately 1.5%. Generally, 1% is the safe number to say when they ask the prevalence of almost any psychiatric disorder. In case of schizophrenia, the number is specifically 1.5%. Importantly, schizophrenia is more common in men than in women, and the age of onset is also different between men and women. So in men, it usually starts from late teens to early 20s, while in women, it starts from late 20s to early 30s. It makes sense that schizophrenia is accompanied with increased suicide risk because sometimes patients can no longer tolerate the hallucinations and delusions that they experience, and they may unfortunately commit the suicide. The use of cannabis and the incidence of schizophrenia is a very hot topic today. So as we know, the heavy cannabis use can potentially increase the incidence of any psychiatric condition, not only schizophrenia, but any psychotic disorder, mood disorder, or anxiety disorder. So connection of marijuana and schizophrenia specifically is not that strong. For the treatment of schizophrenia, well, we need to prescribe antipsychotic medications. And atypical antipsychotics or second generation antipsychotics are the first line because they have less severe side effects. In particular, they don't have the extrapyramidal side effects, which are the main disturbing, like main concern with the typical or first generation antipsychotics. From the atypical antipsychotics, risperidone is very commonly prescribed for schizophrenia. Importantly, the antipsychotics are very effective for the positive symptoms, but they are not that much effective for the negative symptoms. This was especially true for the first generation antipsychotics, which mostly block the D2 dopamine receptors. But now the second generation antipsychotics are much more advanced, and they have so second generation antipsychotics also have some effect on the negative symptoms as well. Okay, now two other disorders that we need to compare and contrast the schizophrenia to are brief psychotic disorder and schizophreniform disorder. The first most important distinguishing factor between these two is the time frame. We already mentioned that the patient should have the symptoms lasting at least 6 months in order to be diagnosed with schizophrenia. If the patient has at least 2 symptoms characteristic of schizophrenia, but the symptoms last from 1 to 6 months, then this is schizophreniform disorder. And again, schizophreniform disorder does not have to be accompanied with decreased psychosocial functioning. And then we have the brief psychotic disorder, and it's called brief because it lasts less than 1 month, and it's usually stress related. And brief psychotic disorder needs to have at least one positive symptom. So you may have just only one positive symptom, let's say hallucinations, for less than a month, and this patient will be considered to have brief psychotic disorder. So in contrast to the schizophrenia and schizophreniform disorder, brief psychotic disorder doesn't have to have the negative symptoms. Okay, now let's talk about the schizoaffective disorder. Let's break down the word itself, schizoaffective disorder. As the name implies, this condition contains the symptoms of both schizophrenia and the symptoms of the affective or mood disorder, either major depressive disorder or bipolar disorder. The main challenge about schizoaffective disorder on the in the questions and also in real life is to differentiate schizoaffective disorder from the mood disorder with psychotic features. When we move on to mood disorders in the next episodes, we'll talk how mood disorders like major depressive disorder or bipolar 1 can present with psychotic features. But in that case, mood symptoms are prominent, so they are classified as mood disorders with psychotic features. In schizoaffective disorder, we have both schizophrenia symptoms and the mood disorder symptoms. But in order for the patient to be considered to have schizoaffective disorder, the psychotic symptoms should last more than 2 weeks without a manic or depressive episode. If psychotic symptoms last more than 2 weeks without the mood episode, it means that the patient has the independent component of schizophrenia in his or her diagnosis. Therefore, she or he will be diagnosed as the schizoaffective disorder rather than mood disorder with psychotic features. Okay, let's move on to the delusional disorder. As the name implies, the person with delusional disorder has at least one delusion, and these delusions should last more than 1 month. Importantly, the patient with delusional disorder has no mood disorder symptoms either those of major depressive disorder or bipolar. And additionally, the patient with delusional disorder should not have the other psychotic symptoms like disorganized thought and speech or hallucinations. If he or she has the other psychotic symptoms, then we either talk about brief psychotic disorder, schizophreniform disorder, or schizophrenia. Another very, very important factor in delusional disorder is that daily functioning and socialization is largely unaffected and intact, except for the area which is influenced by the delusion. And commonly, delusional disorder can be shared by the individuals who are in close relationships. They may be the family members or the partners or close friends. And this phenomenon of sharing delusion is called folie à deux. Folie à deux means the midness of the two. This usually happens when the person with delusional disorder is influential and authoritative for another person, and that other person shares the same delusion. Okay, and finally, the final topic of our today's episode is the schizotypal personality disorder. You may wonder why we are discussing schizotypal personality disorder here, along with the schizophrenia and other psychotic disorders. The reason for this is that schizotypal personality disorder is the personality disorder, but it's also in the schizophrenia spectrum. We'll talk about the schizotypal personality disorder in a great detail when we move on to the personality disorders, but what I'd like to tell you here is that schizotypal personality disorder patients have weird beliefs and the weird and strange ways of expressing themselves, but they have intact reality perception most of the times. In contrast to the psychotic disorders like schizophrenia, schizoaffective disorder, brief psychotic disorder, patients with these disorders have impaired reality perception. Patients with schizotypal personality disorder may actually have brief episodes of psychotic symptoms, especially delusions, but these psychotic episodes are very rare, and for all intents and purposes, they are very mild compared to the psychotic episodes in schizophrenia. Okay, now we've come to an end of our today's episode, and let's revise everything that we've discussed in this episode. We started our today's episode by discussing the childhood psychiatry disorders, including ADHD, autism spectrum disorder, specific learning disorder, Tourette syndrome, and many more others. Then we continued our episode by discussing the orientation and the different types of amnesias. We also talked about the dissociative disorders and delirium. Then we defined what psychosis is, and finally we talked about the schizophrenia spectrum disorders. You can leave the voice message on this episode to let us know how we can improve our podcast for you. So thank you for your kind attention to us, and see you on the next episode.